Assalamualaikum warahmatullahi wabarakatuh. My name is NISA binti JAMALUDIN. My group name is STAR. First of all, I would like to introduce my team member. The first presenter is AZLIZA, the second is SYAMIRAH, and the last one is Amalin AISYAH. Today, we are glad to share about HIV.
HIV can be transmitted through a variety of ways, including first, transmission from mother to kid via pregnancy, delivery, or breastfeeding. Second, having intercourse without using a condom with an HIV positive person or using HIV treatment or prevention medications. Third, through oral intercourse. And lastly, sharing the needles or syringes with an HIV positive person. It is also possible for health professionals to be injured by a sharp object, such as a needle, although it is extremely unlikely that this will result in HIV infection. HIV will attack the person's immune system when it went inside someone's body. HIV will make copies of itself when they get inside the CD4 cell, which is the white blood cell, and then the new HIV will find another CD4 cell and do the same thing. The CD4 cell will be destroyed by HIV once they clone themselves. This cycle will continue over and over again, and HIV will increase in the body. HIV is divided into 3 stages, which are acute HIV, chronic HIV, and also AIDS. When someone obtains HIV, the acute infection begins right away. During this phase, in the body, the virus is reproducing at an alarming rate, and there are a big amounts of HIV present in someone's blood. They are very contagious. After the virus has been infected, acute infection symptoms might appear days to weeks. Some patients will get flu-like symptoms because of the body's natural defense mechanism against infection. The acute stage may survive from a few weeks to several months. Besides, the next stage is the chronic stage. During this stage, someone can spread HIV, and although it reproduces at a very low rate, HIV is still alive and well. Someone may not get any symptoms or become sick during this time. The amount of HIV in the blood increases while the CD4 cell count decreases. Someone may develop symptoms as the virus levels in the body rise and will progress to stage 3. The stage 3 of HIV is AIDS. This stage is the most dangerous stage of HIV infection. People are diagnosed with AIDS when their CD4 cell count falls below 200 cells per cubic millimeter. AIDS patients have severely reduced immune systems, making them vulnerable to a rising number of dangerous illnesses, also known as opportunistic infections. If they do not receive therapy, people with AIDS have at least 3 years to live. Moreover, AIDS patients can have a high viral load and be very contagious.
Assalamualaikum warahmatullahi wabarakatuh. My name is SYAMIRAH binti Muhammad NAZRI. My student number is 20208438838 and I'm from group D2. So today I would like to explain about clinical manifestation of HIV infection. First, neurological manifestation. These disorders are characterized by several dysfunctions such as decrease of attention, mood alterations, depression, psychomotor disturbs, alteration in the extrapyramidal movements, and spasticity. Next, oral manifestations is divided into 2. First, oral candidiasis have 4 types. First type is the erythematous types, also called atrophic candidiasis, appears clinically as multiple small or large patches and is most often localized to the tongue or palate. Second, pseudomembranous candidiasis, also known as oral thrush, is characterized by the presence of multiple superficial creamy white plaques that can be easily wiped off, revealing an erythematous base. Third, hyperplastic candidiasis appears white and hyperplastic, and cannot be removed by scraping. This form of oral candidiasis is rare in HIV-infected individuals. Lastly, angular cheilitis is characterized by the presence of erythematous fissures at the corners of the mouth. It is usually accompanied by another form of intraoral candidiasis. Next, other oral manifestations is linear gingival hyperplasia, which is characterized by the presence of a 2 to 3 mm red band along the marginal gingiva and is associated with diffuse erythema on the attached gingiva and oral mucosa. Next clinical manifestation is skin manifestation, which have four. First, herpes simplex virus (HSV), herpes simplex virus or HSV infection is very common in the setting of HIV. Herpes labialis caused by HSV type 1 occurs around the nose and lips. In the HIV setting, it tends to be more aggressive and lesions last longer. Herpes genitalis caused by HSV type 2 is the most frequent genital ulcer disease in HIV patients. Herpes genitalis presents as vesicles, eruptions, and ulcers on the anogenital area. Next, herpes zoster is common in HIV and tends to be multidermatomal. In HIV, it may cause disseminated cutaneous disease, and HIV patients tend to have recurrent episodes. It presents as painful vesicles following a dermatomy. Third, syphilis is common in HIV, especially in HIV-positive men who have sex with men. Syphilis and HIV frequently tend to occur together because both are sexually transmitted and the risk factors for acquisition are the same. Furthermore, ulcers of primary syphilis tend to facilitate the transmission of HIV. HIV-infected patients with primary syphilis tend to have multiple chancres compared with non-HIV patients. HIV-infected patients with secondary syphilis tend to have genital ulcers of primary syphilis, thus they have an overlap of primary and secondary syphilis. Lastly, molluscum contagiosum is caused by a pox virus and is common in HIV patients. Typical lesions are skin-colored, dome-shaped papules or nodules, often with a central embolization. Lesions may be quite extensive in immunocompromised patients. In HIV, lesions may be atypical and resemble other conditions such as bacillary angiomatosis. Another clinical manifestation is hematological manifestation. First, anemia is the most common cytopenia observed in HIV-infected individuals and is often associated with other cytopenias. Factors causing anemia in HIV-infected individuals can broadly be divided into three main categories. First, decreased red blood cell production in the bone marrow. Second, increased red blood cell destruction, and lastly, ineffective red blood cell production due to nutritional deficiencies. Next, thrombocytopenia. The main causes of thrombocytopenia are inadequate platelet production or autoimmune-mediated platelet destruction. Lastly, neutropenia. The wide range of frequencies reported for HIV-associated neutropenia is likely to be associated with the severity of HIV disease and the use of prophylactic drugs such as cotrimoxazole, which is known to cause bone marrow suppression through the inhibition of folic acid metabolism. A low CD4 T cell count and high HIV plasma viral load are risk factors for developing neutropenia.
HIV is incurable, however, it can be treated with medicine. HIV can treat with antiretroviral drugs. The first antiretroviral drugs is integrase inhibitors. Integrase inhibitors block the viral enzyme integrase from incorporating the viral genome into the DNA of host cells. They prevent DNA strand transfer, inhibiting the insertion of proviral DNA into the host cell's genome. The drugs of integrase inhibitors is raltegravir, dolutegravir, and cabotegravir. Next is nucleoside reverse transcriptase inhibitors. These precursors are used by retrovirus to replicate viral DNA. When the drug incorporated into viral DNA, the chain becomes faulty and viral replications cannot proceed. HIV uses reverse transcriptase to convert RNA into DNA. Reverse transcriptase and reverse transcriptase inhibitors are used to stop HIV replication. HIV uses reverse transcription to convert viral RNA into double-stranded DNA, which is integrated into the nucleus of the host cells and hijacks its genetic mechanisms. The drugs of nucleoside reverse transcriptase inhibitors are abacavir, didanosine, lamivudine, and stavudine. Next is non-nucleoside reverse transcriptase inhibitor. They bind to HIV reverse transcriptase, induce conformational change that cause enzyme inhibition. They can increase T cell counts, reduce viral loads, and transmission of virus to fetus. The adverse effects of an NRTI are allergic skin reaction, include serious Stevens-Johnson syndrome, abnormal increase in liver enzymes, liver toxicity, and efavirenz, such as dizziness, headache, vivid dreams, loss of concentration, and teratogenic. Next, protease inhibitors. They preventing the enzyme protease from doing its job. Inhibit HIV protease, an enzyme needed to convert newly synthesized viral proteins into mature enzymes and structural proteins, non-infectious virus. Protease inhibitors assist to reduce the development of HIV. They accomplish so by preventing HIV cells from developing and maturing by inhibiting the enzyme protease. By inhibiting protease, the virus is unable to replicate. Pharmacokinetics of protease inhibitors is metabolism is extensive and very little of the protease inhibitors are excreted unchanged in urine. Dosage adjustments are unnecessary in renal impairment. Apart from that is entry inhibitors, preventing the virus from attaching to or entering healthy host cells, as their name suggests, interferes with the binding, fusion, and entry of an HIV vision to a human cell. The drug of entry inhibitors are enforvirtide and maraviroc. In addition, is fixed-dose combination. It can help with adherence to an HIV treatment plan by lowering the number of tablets a person must take each day. And the last one is pharmacokinetic enhancer. They increase the concentration of protease inhibitors in the circulation.
That's all from me and my team member. Thank you for watching.